Good morning, everyone. Thanks for joining us for today's pain management echo clinic. First of all, I want to go around and have everybody introduce themselves. So we'll start with the group here. I'm Troy Jorgensen, program coordinator for Project Echo. Go ahead.
Yeah, so hey, Dr. Patterson here. A lot of familiar faces, but I do see a few new ones. So it looks like top left here we have the Renal Tribal Health Center.
Don't see anybody in there.
I don't see anybody in there yet, so we'll skip on them.
And then it looks like William B. Ryrie. We have Dr. Norm Christensen. Good morning.
Good morning, Dr. Christensen. How are you?
Hello. And then Kenzie, and is Patty there with you as well?
I'm in the room.
Ah,
In the room.
so Kenzie, what do you do?
I'm a PA student through Idaho State University.
Idaho State University. I don't even know what their mascot is, or I'd say go, Rams or whatever they are.
Bengals. Yeah. The Bengals.
The Bengals.
Go Bengals. Good morning. Thank you for joining us.
Yeah, thanks for having me.
And then Tony, is that Tony Insara?
Yes. Hi, good morning.
Good morning.
Good morning. Where are you joining us from, Tony?
Southline Medical Center.
Nice. Well, thank you for joining us.
Good to have you.
And then we got
Nikki.
Nikki, how are you?
Good, thank you.
Good.
I'm Nikki Green I live in Winnemucca and I work in Battle Mountain Clinic.
Great. Good morning.
Good morning.
Wonderful. And then Trent, is that Trent Decker?
Good morning, Trent. How are you?
Maybe no audio this morning. So then we'll go to Dr. Michael Koss.
Dr. Koss, it's been a couple of weeks since I saw you. How are you?
Good. How are you?
I'm doing good.
Good to hear.
Thank you for joining us.
Yeah.
My pleasure. Thank you for having me.
So we'll open it up right now, see if anybody has any cases or questions they want to ask before we get going today. Anything out there?
Any cases or any patients that people are struggling with that they want to discuss today with all of us? Okay. Well,
Awesome.
we got like 20 minutes. I'll probably start this presentation, and then we can even actually finish it next time, depending on how far we get. But today's topic, I'm going to talk on the role of spinal cord stimulation and targeted drug delivery for the treatment of chronic pain. And here's my contact information. Just as I was alluding to earlier, Nikki emailed me. My email is at the bottom of this. I mean, anybody who emails me, I'll get back to you usually that day. Worst case scenario, within 24 hours. I'm pretty anal retentive about that. I should probably learn to ignore my email a little bit more. But unfortunately, I'm pretty quick.
You are quick.
So feel free to email me any questions, concerns, or worries. And so talking, about pain. So what is pain? Just as Paul was describing earlier, it's your body's natural response to an unpleasant sensory or emotional experience that is actually associated with actual tissue damage. So when you feel something, your brain assumes that there's something ongoing or damage currently happening to your body tissues at that time. And unfortunately, in the situation of chronic pain, that signals got turned on and it never got turned off. And we don't know why that happens. Something happens within the neuronal circuitry that turns that signal on, and it just, for some reason, doesn't get turned off. And so that's what's difficult with a lot of chronic pain patients, is trying to let them know, like, hey, it's all right to use that arm. It's all right to use that leg. There is no ongoing tissue damage. It's okay to be active, but they fear being active, thinking that they're going to be potentially do more harm to that extremity or that area that has chronic pain. And if you break pain down, there's two different types of pain. There's neuropathic pain, and this is generated and perpetuated by the nervous system. And this can be initiated by a trivial injury, like you stubbed your toe, or it actually can be due to you had a surgery and the nerve got cut, or you had a lesion to your central nervous system, like a stroke or an MS plaque. And usually, the pain is independent of the initial triggering event, meaning that once that event happens, the signal gets turned on and it just never gets turned off. And sometimes there's really not a specific pathological condition to relate to why it's there. The second type of pain is nociceptive pain. This is more a mechanical or inflammatory etiology. So this is where there is actually, like you cut your finger, you got hit or involved in a car accident and sustained bruises, and there's an inflammatory reaction in those areas. This pain, nociceptive pain, can be either somatic or visceral in origin. And usually the pain is a direct reflection of how severe the ongoing tissue injury is. So if you just barely stubbed your toe, it barely hurts. If you broke your toe when you stubbed it, it's going to hurt a lot more. Typically, nociceptive pain is very well localized. It's exactly where the pain is located. And it usually will respond very well to anti-inflammatories or analgesics, Medrol dose pack or NSAIDs. And then, there's a third class that can be a mixed pain pattern. You may have patients who have neuropathic pain and nociceptive pain, and so those are a little bit tougher to treat. And I'd say with my spinal cord stimulator patients, I see that if somebody has, failed back surgical syndrome, a lot of times, especially if they've had a fusion, they'll develop nociceptive pain above and below the fusion because those joints become arthritic. But they've got the chronic radicular pain, the pain down their leg, and I put a stimulator in them, and they'll tell me that well, God, doc, this is great. My leg pain is gone, but my back still hurts. Why isn't it helping my back? And that's usually because stimulators don't help nociceptive pain. And so a lot of those patients, you're going to tell them, hey, we need to look at other treatments to treat those joints to help that pain because it's more mechanical in nature. So let's talk a little bit about spinal cord stimulation. And I'll throw this out there. Does any of you guys have patients with spinal cord stimulators? It sounds like Patty has a patient currently being worked up for a stimulator. Is Patty still in the room?
Go ahead, Patty, we can hear you.
So Patty, what stage is your patient at? Is your patient being waiting to see Dr. Lewandowski to get cleared for a stimulator, or is he, or do they have the trial and wait for the implant? What stage is your patient at? And I'm getting
for the poster, I do have one patient who currently has a pain stimulator, but the post-herpetic neuralgia patient, he's seeing Dr. Dahlgren.
Yeah.
And the thing about this patient, during the time he's had post-herpetic neuralgia, he was diagnosed, he already had a AAA that needed surgery during this time frame. He had a carotid endarterectomy, and he was treated for prostate cancer. This is all during the time I've been seeing him for post-herpetic neuralgia. And so the pain stimulator has been delayed by the most recent surgery, which was carotid endarterectomy.
Yeah.
And so that happened, it was successful. So I think now they're moving forward on that.
All right, so they're just waiting for his current health issues
Yes.
to resolve in order to be healthy enough to undergo the implantation of the stimulator.
Right. The other patient I have who currently has a pain stimulator, he had failed back surgery. He's about maybe 82, diabetes. And he's actually having what you just mentioned, which is the pain stimulator is treating the spinal pain perfectly, but now he's really struggling with pain on the other side, probably sacroiliac pain. So he's going to pursue facet injections for that because it just doesn't cover that at all. But it perfectly treats the back pain that that it was for.
Yeah. Yeah, I have to say a lot of times I'm doing a lot of blocks and facet ablations on patients who have axial back pain after implantation of a stimulator. And even though you try to explain this to patients when they go through the process, they have a hard time, remembering that you talked about that in the beginning, when they're 6 months in, and why does my back still hurt, doc? The stimulator's not helping. And it's like, well, no, this has always been the case. We've talked about this. But so I'm glad that you're seeing that as a provider, because hearing it from multiple people kind of helps us out.
The question I was going to ask is there a particular pain diagnosis that seems to really work well and respond to a spinal cord stimulator versus kind of what you're saying, other conditions?
Yeah, neuropathic pain syndromes are the ones that you want to look at. So felt back surgical syndrome, chronic radiculopathy, chronic regional pain syndrome, the post-herpetic neuralgia. I mean, these are all excellent conditions that can respond. And a lot of times what I'll end up asking the patient is, I ask a simple question, when I'm thinking about, a pump or a stim to help their chronic pain, and this is real simple, as I'll say, I'll ask two questions. One, is there, and this is more to myself, is the pain more focal or is it more general? Like, do they have head to body, toe pain? A stimulator is not going to help that, but a pump can. So if it's more diffuse pain, I'm thinking pump. If it's more focalized pain, I'm thinking stim. And then the second question I'll ask the pain is your pain there 24 hours a day, 7 days a week, 365 days a year? And it doesn't matter what you do. And if the answer is yes, it's always there. It just varies in intensity. Then I'm thinking more stimulator. If they tell me, well, God, doc, if I just lay down, put my feet up and watch some TV, I don't have any pain. Then I'm thinking that's more mechanical or activity induced, which seems to me more of a nociceptive type pain. And so in those cases, I don't think a stimulator is going to help. I think a pump would be more of the solution for those patients. Spinal cord stimulation is it's been around for 50 years. I don't think a lot of providers know that. We've been doing it since 1967. It's FDA approved for the management of chronic pain, and specifically works really well for neuropathic pain, as we were discussing. And it's covered by all major health insurances, including Medicare and workman's comp. Unfortunately, in the state of Nevada, it is I think it's a recognized benefit, but the problem is the reimbursement is less than the actual device. So a lot of times it's a losing proposition, and a lot of times when I go to the hospital, the one or two cases I've done, I get pulled aside by the hospital administration, kindly reminding me that they lost money on that stimulator case.
Wow.
So I think I've only done one or two Medicaid stimulators in my 12-year career because of that. But all other insurances, it is a covered benefit. And if you look at the articles over time that we've seen is that, benefits of neurostimulation is it can reduce patients' pain. It can improve their function. It can improve their quality of life. It can actually get or eliminate the use of pain medications. And that's actually something that my office is going to start looking into now. Is I think we're going to do a retrospective 2-year study on my partners and I's patients and how successful we were with getting a stimulant in patients and what their current opioid use is 2 years later. So hopefully we'll see that it drops significantly. Basically, what a neurostimulator is doing is it's providing electrical pulses along the nervous system, and basically trying to change that signal to the brain, or how the brain perceives that signal. So almost kind of like the gate control theory that you hear back from Wall.
Yeah.
Exactly. With traditional stimulation, which was tonic stimulation, which is where the patients feel the actual stimulator, they'll, instead of them saying, well, God, my foot feels like it's a dull toothache, or, that's 9 out of 10. A lot of times what will happen is you'll put a buzzing sensation in that area, and the patient will say, well, God, now I feel more of a pleasant massage. My pain's only like a 3 out of 10. It never really would eliminate the pain. It would just change the way they perceive it. Crazy enough, and I'll talk about it coming up, is that there's been a lot of advances in spinal cord stimulation over the last, several years, that we're kind of in a golden age now, where we have stimulators that you don't feel anything. You just get the pain relief without feeling it. And on top of it, they've got batteries now that you don't have to interface with, meaning that the stimulator, works for about 5 years before the battery dies, and then you got to change the battery.
I'm curious, do you have what do they do different? How do they get rid of that tingling sensation?
So one company, a company by the name of Nevro, changed, I guess, prior batteries for stimulator companies. They're limited in how high the frequency can go.
Mm-hmm.
And so I think most companies could only go to 1,500 or 2,000 hertz. And Nevro took a battery and undid it and found out that if they went to 10,000 hertz, that you no longer could feel the vibration when you change the setting. That's a very high energy output, though. In traditional stimulators, tonic stimulators, since the hertz was so much lower, it's usually about 20 to 40 hertz that we had put patients on. You had to, if you had a rechargeable battery, you'd have to charge your battery every 2 to 3 weeks, probably on average. With the Nevro system, you still have to interface the stimulator because you're using such high energy output that you have to charge that battery once a day. Okay. So that's one disadvantage of some, the Nevro, the newer system. It is paresthesia free. You don't feel it, but it's such a high energy output that you have to recharge your battery. Now, one of the other companies had a new waveform or a proprietary waveform, which I have in my presentation from Abbott Medical. It's called Burst. Burst is a train of impulses that are sub perception. The brain can't. Your brain receives it, but the patient can't see it. So it's kind of more like a dog whistle.
Yeah.
But that is a train. Then it stops. It turns off. Then it turns back on. Then it stops. And so that's a lot lower energy. You're still in the 20 to 40 hertz. And so in that case, technology in lithium batteries have gotten so good that they can actually now offer one battery that it could last anywhere from 3 to 5 years, depending on their other settings. Wow. And a little bit bigger battery that can last 5 to 7 years. So it's become more like a pacemaker.
And can you retrain the nerves, or through function, while they're not feeling the pain, actually get off of the stimulator after time?
There are some cases where you're correct. You put a stimulator in, and that signal can potentially rewire the brain. Yeah. And after a period of time, they're like, I just don't need the stimulator anymore. There's also, I've seen some cases where you turn the stimulator on, there's what I call a washout period that, when they turn it off, they still feel good for a period of time. And then, all their pain will return, and then they turn the stimulator back on. So I have one gentleman who has chronic foot pain from failed back surgical syndrome, and he would turn his stimulator on for about 2 to 3 hours. Mm-hmm. 2 to 3 hours, his foot pain would go away. At that point, he would turn the device off, and he would tell me that it'd take 5 to 6 days before the pain would come back. Wow. He'd turn the stimulator back on for 2 to 3 hours, and then turn it off and go away. And so he was only using the stimulator for 2 to 3 hours a week.
It's a tool.
Yeah.
Yeah, it's kind of like putting your foot on the gas pedal and then taking it off and
coasting,
getting better gas mileage or better pain relief. That's interesting.
Yeah.
And getting more function all along the way.
Yeah. Exactly.
Okay.
So patients who are good for, a good candidate for stimulators is anybody who has chronic pain. So if they've had pain for greater than 6 months. It's neuropathic in nature. Typically when I'm looking at patients, I'm thinking neck or arms or back and legs, more kind of a focal pain distribution. A lot of times physicians will ask me if the pain is burning, tingling, or kind of a numbness. Those are signs of neuropathic pain. But what I've found is that if you just ask them, is the pain there 24 hours a day, 7 days a week, 365 days a year, there's got to be a neuropathic component to it. And then, obviously you don't want to have a patient be in a car accident one day and you're throwing a stimulator in the next. You want to make sure that they've failed all conservative care. Did TENS units, topical TENS units not help, oral medications, nerve blocks, physical therapy, or, heaven forbid somebody has a 1-level disc herniation that's obviously pinching a nerve, get a microdiscectomy to treat that problem. If they'll be cured by a simple surgery, do that before you consider putting a stimulator in who's not a candidate. You know, obviously patients who have psychosocial issues. I think in the upcoming weeks, Dr. Lewandowski is going to talk about doing a evaluation for patients who are stimulator pump candidates and trying to determine if they're a good or a bad candidate, which is, you know, I always appreciate. I have to say, you know, I have 1 or 2 explants a year, and a lot of times when I go back and look at it, it was typically a patient who wasn't cleared by, you know, pain psychology initially, and they needed several CBT treatments before they got cleared, and then it seems like after I put the device in them, they just forget to treat their mental health issues. They you know, because they think I did jump through the hoops to get the device, and then 6 months later, you know, this isn't working. I want it out. And it's really not a mystery to me. So a lot of times now, I'm almost hesitant if it didn't get cleared from the get-go to even consider putting the device in them. So, you know, patients who have ongoing depression who are the cause of their pain, patients who cannot operate the system. You know, like I was saying in the past with tonic stimulation, you had to interface it all day long. You had to turn it on, turn it off, turn it up, turn it down. Now, you know, it's gotten better where it's a forgettable therapy, meaning that I can implant it, turn it on, and then the patient doesn't have to interface it. But if the patient doesn't like that system and they want tonic, they got to be able to interface the system and control it. You know, if patients get their trial and it doesn't give them pain relief, no need to put a permanent device in them. The great part about neurostimulation is you try it before you buy it. It's kind of like, hey, I think that car is beautiful. I'm going to go to the dealership and buy it. Well, guess what? How about the dealership lets you drive it for a week?
Yeah.
And then you decide if it's got all the features and functions you like. That's the nice part about a stimulator. You know, patients come to our office. It takes, you know, 5 to 10 minutes to put the leads in. It's no different than doing an epidural. You know, instead of injecting steroids, we're just putting leads into the epidural space and putting them over a neural target that we want to stimulate. And then we, you know, tape it down and let the patient use it for 5 to 7 days. 5 to 7 days later, they come back in. We take off the tape. We pull the leads out. Nothing permanently has been done to them. And at that point, you know, I typically ask patients 4 questions. 1, how much pain relief did you get from the trial? 2, was your function improved in this, you know, over that period? 3, if they have them on short-acting pain medications, did you decrease the amount of short-acting pain meds you needed because your pain was better controlled? And then 4, I usually ask them what's their overall global satisfaction with the trial. You know, how happy were you with it? Obviously, if a patient comes in and it's 80% pain relief, my function was improved, and I barely used any pain medications this last week, it's a home run. Let's go ahead and put it in. You know, it gets a little dicey when patients are like, well, I got 30% pain relief, my function was improved, I really didn't decrease my pain medications, but I'm 100% happy. You know, and I'm like, well, you know, your insurance is gonna, you know, say that you have to get at least 50% pain relief in order to move forward with the device. And, you know, I hear a lot of people change their mind on how much relief they get, but, you know, you don't want to coach them through it either. You want to make sure that they're picking it because it's actually helping them. I've seen situations where, you know, I think, you know, you look back 6 months later, the patient's asking for it out, and I look back and they report, and I tell them, well, you reported this. Well, doc, I was just real hopeful.
Yeah.
Like, I just wanted this thing to work, and so I had you put it in me thinking that it would get different with a permanent implant. And that's very disheartening to me, because then I feel like I got sold a bag of rocks, you know. And so, during, like I said, the evaluation period, you know, it's a short procedure. They come to the office. It usually takes 5 to 10 minutes to put the leads in place. We test it on the table to make sure we got coverage, tape it down, and then we send them home. And I tell them to do all their normal activities for that 5 to 7 day period. Some physicians will do it for 3 days. A lot of times I'm in contact with the rep. He'll text me daily on how my patient's doing, how successful it is. If I know before then, I want the trial to implant timeline to be as short as possible. So if I know by day 2 or 3 the patient's telling the rep that it's very successful, they want the permanent implant, I'm already going to my scheduler and having them find OR time to get them in to make that time as short as possible. I've seen some cases where somebody gets the temporary out, they're very happy, and then something happens, and then 2 months later and I'm like, well, hey, we had success when we're going to schedule the surgery. They become like, well, I'm not sure anymore. They can't remember how well it works. So I try to keep that period as short as possible. Or I've noticed that if I take it out and I tell a patient, well, oh, I've got a conference to go to, I'm going to put this in 3 to 4 weeks, they get angry. Like, so, so I try to take the trial out and put a permanent implant as fast.
From a product standpoint, Dr. Patterson, do you have any? What are there different kinds of spinal cord stimulators?
Yeah, there's 5 different companies out there.
Yeah. 5?
There's 5.
Wow.
So to me, I kind of look at them in 2 classes. I look at your tonic stimulators, and so the 3 companies out there that really only offer a tonic stimulator, which is old technology in my period, would be Medtronic, Boston Scientific, and Nuvectra. And if you're talking about paresthesia-free, new proprietary technology, you look at Abbott and Nevro. They've got, in my opinion, the best stimulators with level 1 evidence showing that they work, where the other companies really have the same technology for the last, 20, 30 years.
Any other variables that are important for a patient to know? For example, can I get an MRI in the future with this product or not?
Used to be that you're right, that there was a race for different companies to get MRI compatibility.
Yeah.
But they now pretty much all have MRI compatibility.
Okay.
And if they don't, they have device, the patients who get the devices in, if they're just pending an FDA approval for it. So that's pretty much gone by the wayside.
Okay.
And so kind of, we're talking about tonic stimulation, so that gets to your question. So Abbott Medical has BurstDR Stimulation. And so burst stimulation is, when you look at pain pathways, you look at the lateral pathways. This is where the patient will come in and they'll say, describe your pain. And this is what the lateral pathway is. Well, my pain's over my lateral foot. It feels like a dull toothache. And I put it as an 8 out of 10. It's miserable. But there's also part of there's a medial pain pathway that we never really talk about. And that is more of the emotional aspect or suffering part of pain, right? So I've seen in the past where I put a tonic stimulator in patients and they'll tell me their pain is better, but they are emotionally still suffering. Yeah. Doc, well, even though my pain's better, I still can't get off the couch. They're still perseverating about their pain. So, you got to think about when you're not just treating the pain, you're actually treating the suffering. And the patient's overall global pain is a combination of the 2 to them. Well, what we've seen with BurstDR is that if you look on the bottom left here of the screen, that's tonic stimulation. That's where you get the same signal repetitively over and over. With BurstDR, we see a buildup of energy. So you have about 5 spikes, it builds up of energy, and then you get a release of energy. And what we've noticed is that the thalamic neurons in the brain can fire in both tonic and burst modes. But when they fire in burst, that is a more potent activator of the cortex. So Abbott Medical is mimicked and trademarked this burst firing pattern. And what we find is that when we do functional MRIs, we find that not only does it light up the lateral pathway, but it also lights up the medial pathway. So a lot of patients now, we can actually treat their emotional suffering with pain by putting this device in. So not only are we, treating their pain, but we can also treat their emotional component as well by having this other pathway. So in my opinion, I can honestly tell you, with Abbott, I put the device in. I basically am giving patients 2 for the price of 1, meaning that the first 5 days I'll put them on burst, and if they respond, then I'll implant them with burst. And then if they fail down the line, I can always flip them to tonic, the old stimulation, because that device.
With the same device.
With the same device.
Wow.
If I do a burst trial and they don't get relief after 5 days, I have them come in, I turn it to tonic, and I extend their trial out another 5 days. So other companies just have.
Do you have any experience of
response
of how many patients respond to the first phase, and then don't, and then do respond to the emotional
question.
suffering?
So I can tell you, since burst became available in October of 2016, prior to that, I looked at my trial conversion ratio, and I was about 84%. 84% of patients who got a trial went forward with a permanent implant. since Burst came out, I've shot up to 94%.
Wow.
And that's not saying Burst is perfect,
Right.
but it tells me that, you know, if Burst fails, I flip them to tonic.
Yeah.
But I can just think off my head in the last 2.5 years, there's probably only a handful of patients that have gone on to tonic,
Okay.
that have moved on to tonic. So that's you know, some pretty cutting edge stuff. The other thing that's interesting too is that with spinal cord stimulators, you worry about habituation. Habituation is where that's, you know, with tonic stimulation, that signal's always going. Your brain eventually just can subtract it out. And usually we see that happens about the 1 to 2 year mark. And so with traditional stimulation, we call it 50-50 club. 50% of patients would benefit long term, and 50% of them eventually would fail the therapy. So you had a coin flip chance of helping those patients. With Burst, since what we're trying to do now is we're looking at what we call microdosing. And our office actually is involved in a study called BOLD. And if you look it up, Abbott just released an AP press release talking about the results of BOLD. And our office had 50% of the patients in the study. So here in Reno, Nevada, 50% of the patients in this BOLD study came from my clinic. And what we found is that we can have that signal on for 30 seconds. So you turn Burst on for 30 seconds, and then you can turn it off for 6 minutes.
Mm-hmm.
So the brain can't habituate to it. And what we find is that the patients don't, since they don't feel anything, they don't know that it turned off.
Yeah.
And what we found is that 44% of patients get sustained pain relief with that 30 on, 60 off. So earlier I told you the battery was going to last 3 to 5 years.
Yeah.
Now with that, we can make the battery last 7.5 years.
Wow.
So now patients are going to need their battery changed less frequently and get sustained pain relief. And so far, you know, it's only been out for 2.5 years, but I have not seen any patients develop habituation to the BurstDR signal. So pretty cool that our clinic is, you know, got a national press release, and 50% of the patients that caused that press release came from Reno, Nevada. The other thing to look at is, you know, traditional stimulation was, you know, stimulating the spinal cord. We've now have advanced to the point where we've got novel targets too. And so now you can actually stimulate the dorsal root ganglion. The dorsal root ganglion is what attaches the peripheral nervous system to the central nervous system. And previously, we saw a lot of limitations in spinal cord stimulation, that meaning it was very unspecific, especially tonic stimulation. You turn it on, and patients would say, Doc, my foot hurts, but why do I feel the stimulator from the waist all the way down to my foot? I just want to, you know, feel that vibrating in my feet. Or I don't have pain in the other leg, why do I feel vibration in both legs? Mm-hmm. The other thing that we saw with traditional stimulation, it was unstable, that the spinal cord moves. And so as the patient sit, stand, roll over in bed, the stimulation would increase, decrease, depending on the position the patient was in. And a lot of times they didn't like that. And if they felt that vibration, they'd turn down the stimulator. And what we're realizing is that they'd probably turn it down to the point where it wasn't helping them. It wasn't in a therapeutic window. And the other thing that we're talking about is when you're trying to stimulate the cord, you got to push energy through the cerebral spinal fluid. That you know, increases your energy output. What's nice about the dorsal root ganglion stimulators is now we can get more specific. So if you got foot pain, I can put a lead over the L5 or S1 DRG, and I can stimulate the foot only. You don't feel the stimulation anywhere else. I can get that dermatome perfect. The other thing that we look at is that it's predictable, meaning that as the patient moves, that lead stays so close to the DRG that the stimulation stays consistent. They don't feel more or less with positionality. And then there's really no CSF surrounding the DRG, so you don't have to push a ton of energy. So now instead of using amps, we're using microamps to stimulate the DRG to sustain pain relief, which then has allowed the batteries to last even longer.
Is there, maybe we could carry this up next time?
Well, that's what I was going to say. I was going to say it's 9 o'clock. I know people got to get to the clinic. And probably what I'll do next time is I can go a little bit deeper into dorsal root ganglion stimulation, since that's been a home run. I can tell you I've put probably 80 of these devices in 2 years, and I haven't had a single patient ask for it to be taken out.
Wow.
which, I still have about 2 to 3 explants with traditional stimulators every year. But any questions on any of this before we go today? Well, I appreciate your time. Hopefully I didn't babble, and hopefully it all made sense.
Thank you, it did.
Yeah, thanks everyone. Great discussion and interaction at the beginning there. So we'll hope to see you. Let me get the calendar here and see what the date is on that one. I believe it's Wednesday, March 6th. We'll be back. So we'll finish up Dr. Patterson's talk, and then Mike, is it you?
Yeah.
So we could talk about the screening part of this whole talk today. So
very stimulating, Dr. Patterson.
Thank you. Thanks everyone.
All right. Thanks, guys.